Welcome to our meeting, everybody who's attending. Thank you very much for joining us today. All right. I hope that you're all dealing well with the coronavirus. Hopefully by now, all of you have gotten full vaccination and are living a much easier life. We'll still be live streaming until likely the end of the year, or at least the near future, on the third Saturday of every month. And hopefully once the whole COVID-19 is behind us, we'll be able to meet again in person. Your hosts today are Lyle LaRoche, our president and director, Jean Van Vliet, also director, Bill Manning, director and videographer, John Tassi, our director and webmaster, Steve Pendergast, who does a wonderful job with our newsletter that hopefully you all received by email. Bill Lewis does our meeting summaries, does a wonderful job of writing up very detailed transcripts of both what the doctors present as well as the Q&A. And myself, Aaron Lamb, I'm the facilitator and now taking over doing the video streaming as well. Together as an organization, we have over 900 members and everyone is a volunteer. You can be too. Please do get in touch with us if you would like to offer any assistance or offer ideas on new presenters that you would like us to bring on. Our support to you is in the form of our website, www.ipcsg.org. There you can find our newsletter as well as links to the monthly video streaming, which occurs the third Saturday of each month. We also have a hotline, 619-890-8447 that you can see there. That will put you in touch with one of our directors who can help answer any burning questions that you might have, especially for you new people out there that are looking to navigate your way through the treatment that you might be heading towards. Also on our website, you will find just a lot of useful information. You know, in those newsletters, there's a lot of republications and summaries of some of the latest and greatest research that's going on as well. So I do encourage you to check that out. We do need volunteers to help us recruit and schedule speakers. So if you are interested, please do contact us either by email or the hotline to let us know that you can help. We'd also looking for people who can share their experience, especially in the, perhaps in the last year, if you've received a new type of treatment, a new type of medication that others might be interested in hearing about. Later this year, we'll be having a roundtable and hope to include some new experiences that can be shared with the group. We do also need help taking hotline calls, and contact us anytime as we've given those website and phone numbers before. So we share a patient-focused experience on becoming your own case manager through informing, networking, and caring. We are experienced participants, but we are not medical professionals. And any sharing by anyone in our group may not be a substitute for your medical counsel. We can certainly answer questions about our experience with our treatments, but the hope is to help you make your own best decision for your own care. We are in need of your support. We are a 501c3 nonprofit organization. Therefore, donations are tax deductible. We don't have any medical or religious affiliation. And during the coronavirus pandemic, while we are video streaming our meetings, our costs are very much the same. We do put advertisements in the newspaper in the week before our monthly meeting to try to get in touch with new people, especially those with recent diagnoses. And we also do have costs for keeping our website up and running. So please do make a donation. You can do that online from our website via PayPal, or by sending a check to the address that you see there. That address is also available on the website. Our next meeting next month will have Bernadette Greenwood, who many of you might be familiar with. She's the Chief Research Officer at Halo DX, which is, she's recently transitioned from Desert Imaging to this new company name. She'll be joining us on May 15th. However, today we have Dr. Ross Schwartzberg from Imaging Healthcare Specialists. He has a very interesting title to the presentation that he's going to give, and I'll let him present that. For today, we are going to take questions at the very end. Please feel free to type them into the Q&A section and submit them, but we'll have the doctor address those at the end of his presentation. So with that, Doctor, please take it away.
Well, thanks, Aaron. Let me share my screen here. We'll get going. Okay, good morning. Super cool to present to the group. I'm glad I'm going before Bernadette, not after her, because she's absolutely outstanding. We've been colleagues and friends for many years, and I'm sure she'll give a great talk. So yeah, forgive my Dr. Seuss reference. It's a little silly, but as I was thinking about the talk, I couldn't help but think of Sam I Am and Green Eggs and Ham. But I think aside from the rhyming and the alliteration, I think the questions of gadolinium and its utility and value, and whether there's risk of using gadolinium, I think they're relevant questions, and I hope you'll find this of interest. And for those of you who are Dr. Seuss fans, perhaps you'll remember that Sam I Am is actually the guy with the red hat, and this character is actually never really named. So just framing a little bit about the discussion, we're all about the prostate MRI pathway. I think this group is fairly sophisticated. We're not really going to go into all the rationale, but in a couple minutes, I just want to, go over what we're doing and why we think it's of value. So we just have to remember the serious problems of the traditional pathway, which was taking the non-specific PSA test and going straight to the blind biopsy. This is a slide I borrowed from Peter Pinto, the head of the surgery branch, urologic surgery branch at the NCI. The blind biopsy, hoping you hit the tumor. And it's important, these numbers are directly from the urology literature, that with the blind biopsy or random systematic biopsy, as you probably know, you miss the clinically significant cancers at an alarmingly high rate. You incidentally pick up these insignificant cancers, and you misclassify or undergrade the cancers at a high rate. So even though MRI is not perfect, and we'll talk about that, it's better than the alternative pathway. And we've known that we need a refined screening and stratification tool. This is a quote from Patrick Walsh, a luminary at Hopkins, who essentially invented nerve-sparing surgery. Prostate MRI allows us to see cancer in the gland and find the aggressive cancer that need to be biopsied and avoid those that are low risk. So in the last number of years, multiple major multi-center international trials have proven the concept that MRI pathway detects significant cancers at a much higher rate, grades the cancers appropriately at the outset, and finds the insignificant cancer at a much less rate than the traditional biopsy pathway. And this has led the American Urological Association to update their guidelines. And now they state that sufficient data exists to support the recommendation of MR before biopsy in all men who have no history of biopsy. And that was published online in October 2019, and then put out in their journal in April 2020. Now, importantly, they did put a qualifier here, say when quality prostate imaging is obtained, current evidence supports its use. And I think that's a key point. We have to get the imaging right. We have to do it with high quality. We have to know how to interpret the exams, or if we don't, we get into all sorts of trouble we don't want to have. So just again, to frame the discussion, when you use the term multiparametric, it's taking the beautifully anatomic T288 images and adding on these functional physiologic sequences. Cancer is always going to be dark appearing on T2, but that is non-specific. Benign processes can also look like that. So we need the specificity that we get from this diffusion technique, which shows markedly restricted water movement reflecting cellular density. So now we know that this is not some benign process. This is a highly tumor suspicious area, likely a significant cancer. The other physiologic parameter is the DCE gadolinium that looks at neoangiogenesis. That's a sensitivity technique, meaning it draws our attention to an area that's small and subtle and maybe not well seen on the other techniques. But once you see an abnormality so obvious on a T2 and so obviously abnormal on a diffusion image, you are able to make a categorization, call this a PIRADS 5. The DCE doesn't really inform your decision. So then the first question, what's this about? All we hear about GAD. Well, in 2017, of course, the FDA put out the new class warnings, but the story really precedes that. If you go back to 2006, we started to realize that patients with renal failure who were receiving multiple repeated doses of GAD were developing this devastating process called nephrogenic systemic fibrosis. And then if you fast forward a number of years, in 2014, the first paper came out describing the Galilean deposition process. So here's a picture showing the cerebellum before the patient had multiple injections, and then after multiple injections of GAD, you can see the bright signal reflecting GAD deposition and part of the cerebellum we call the dentate nucleus. And this is another characteristic deposition location is the basal ganglia, the putaminal nucleus, bright signal here after multiple injections, and here, this is what it was before he had multiple injections. So the FDA put out their warnings and noted that there is a definite relationship to amount of administration of GAD, the number of times you've undergone gadolinium administration, that there was some certain types of contrast more likely to dechelate. The term is also called transmetallation, I believe, and therefore was preferred to use certain types of agents. That gets into what's called linear versus macrocyclic, and we've all rapidly adopted to using the macrocyclic type of agents. Let me go back there, skip the slide. So all of the major bodies, the American College of Radiology and the American Society of Neurology, really took all this quite seriously, put out position papers and white papers. And a couple of things to keep in mind. Gadolinium has been around since 1988, hundreds of millions of administrations. When the problem with nephrogenic systemic fibrosis became apparent, there was really rapid adoption of restrictive guidelines and drastic reduction, essentially elimination of these cases, because we just do not give contrast to patients with chronic renal failure. Important to remember, and as a neuroradiologist, I can attest to that, GAD is a very extraordinarily helpful tool to help us with diagnosis and driving treatment. So if GAD is indicated, if GAD adds value, it should be administered. And however, we always need to understand the risk and benefits, whether there's a GAD deposition process or not. You don't want to administer an agent that's not going to add value. Just briefly, another body, the Society for Magnetic Resonance in Medicine, put out a paper, and basically this is in Lancet Journal, said essentially the similar things. Be very cautious. Don't give GAD if it's not going to alter the practice. Don't restrict GAD if it's going to be helpful, and you got to understand the risk and benefits. They acknowledge, of course, the deposition issues, but point out that the clinical and biological significance, if any, is unknown, and that in the preclinical studies, i.e. animal studies, there doesn't seem to be histologic changes when you look at under the microscope of brain specimens of the animals. Again, this is another last one we'll look at, a working group. And if you're a chemist, you probably would love this paper because it really gets into the chemical properties and the biodistribution, looking at thermal stability versus kinetic stability, and stuff way over my head. But what I would take away from this is a couple of things that certainly deposition is dose dependent, and orders of magnitude higher with a linear chelating agent compared with a macrocyclic chelating agent. So all of us, essentially everybody, has shifted to using the macrocyclic chelating agents. And then important to remember and keep in context that if you look at the hundreds of millions of administrations, in the Medicare database, we have not determined definitive evidence of biologic effects of neurotoxicity that can be, directly associated with the observation of the deposition. So then the question becomes, does GAD add value in prostate MRI? And this paper just came out in January 2021. And the issue is, with the increased utilization of prostate MRI, are there ways we can make it more efficient? Can we make it less expensive? Can we shorten it? Can we roll it out to more centers, more access for patients? Specifically, could we look at omitting contrast? And here's some takeaways from this, from their findings, which is, I think, really important. They talk about patient preference. And of course, if you can do the study without an injection, shorter scan time, less time on the magnet, you don't get a poke in the arm, there's no chance of extravasation of contrast, no chance of allergy, and no chance of having any kind of deposition. Other key things are contrast. GAD does not add anything in the setting of a negative MRI exam. So in most populations, including our practice, I'd say 30 to 40% of patients have a negative MRI. So if it's a PI-RADS 1, PI-RADS 2, contrast doesn't add in anything in that setting. At the same time, the positive scans, if you have an obvious abnormality on T2 and diffusion, GAD does not add anything to your final PI-RADS assessment. What they do point out is that GAD helps your less experienced readers. And also, which I don't know if they pointed out in this part, but GAD also is a reliable, robust sequence. And if you have degradation of your diffusion sequence, the GAD sequence can be considered as a so-called rescue sequence. They make a few other comments, which is that if you adopt a biparametric protocol, meaning omitting the contrast, you could institute a safety net callback process. So let's say you're an indeterminate case and you think that GAD will help you, you simply call the patient back. That's the protocol we've used for breast imaging for as long as breast imaging has been around. You have screen mammograms, and if it's negative, it's great. Patient gets a letter, we're done. If there's a question, the patient is called back for the diagnostic. And then they make a point about, artificial intelligence and advanced tools, and we'll talk about that in a minute. So their consensus statement, they talk a lot about image quality, and point out that you need to have optimal image acquisition. And they do point out about how DCE contrast GAD can be a rescue sequence when you have poor quality diffusion images, which does occur. And reading between the lines, I think they're skeptical of truncated protocol when the quality of scans and the quality of interpretation in the community practice outside of expert centers is of concern. And they kind of, are on the fence a little bit, saying we should have both contrast protocols and unenhanced protocols available. Now, I like to see what other smart guys are saying, and this is from the PCRI YouTube, and you probably know about Daniel Margolis. He's at we used to be UCLA, and now he's at Cornell. And he was asked at a patient forum, what's all this about prostate, about insistence on gadolinium. The patient was being followed at Sloan Kettering, and pointed out that Sloan Kettering's protocol is if you're in active surveillance and you've already had your initial prostate MRI to exclude anything, a high-grade lesion that they missed on the biopsy. Once you've had the initial MR with GAD, that they don't use GAD for the follow-ups. And so Daniel Margolis answered, and in general, I would say he's kind of a pro-GAD guy with some caveats. And he talked about the fact that even though there's the deposition issue, that if you look at the hundreds of millions of patients in the database, that in his words, there's no indication there's any neurologic effects. And then quoting him, he says, there may be a risk, meaning of GAD, but there's also a risk to not using the contrast. And as I've shown you, it's crucial for figuring out how large the tumor is. And I'll talk about that in a little bit. He does also point out that diffusion imaging fails and the rescue aspect of DCE. Diffusion imaging is susceptible to bowel motion, to bowel gas, to hip artifact, to urolift device. We use the advanced diffusion technique to deal with those issues, but he's correct that GAD can help in those situations. This is another PCRI thing, and I love to see his different hairdos. Actually, I'm a big fan of his, so if anybody knows him, tell him be happy to come speak with him or be on a panel with him or whatever. But anyway, in this one, he talks about how if you're in a situation or a practice community where there's access issues or resource issues or concerns of cost, it's perfectly fine to do a non-contrast protocol. And he says maybe 1 out of 10 times you'd have to call the patient back. And then at the very end, the question is, but what you're saying is you don't always have to use contrast. And he says, right. Now, I also think, reading between the lines, I think Dr. Margolis is also kind of circumspect about coming straight out and saying we can delete GAD because of the concern of what might happen in the community practices, which are maybe, less committed to high quality imaging and maybe less experienced in interpreting the scans. And if you exclude the robust DCE sequence, perhaps you're going to get into trouble you don't want to get into. So we kind of summarizing this, GAD does sometimes help less experienced readers maybe draw their attention to a subtle abnormality. It certainly does help in the setting of diffusion weighted. When the diffusion images are obscured by artifact, it increases reader confidence for those less experienced readers. And again, as a rescue sequence, there are other ways of dealing with that, particularly advanced diffusion techniques, which are more robust in the setting of bile gas and hip prosthesis and Urolift device. So getting to, the issues with prostate MRI, this is the group that put out the PROMISE paper, which was one of those seminal papers proving the concept of the MRI pathway. Their question in this paper can the impressive results regarding the high negative predictive value sensitivity and the acceptable positive predictive value or specificity that came out of those trials done at expert centers, could they be reproduced and translated to community setting? And their conclusion is it could, but I just want to make a couple points here. We need to remember that MRI, even in the best setting, is not perfect. Meaning, even if you get the highest quality images read by an expert who's tremendously experienced, MRI can miss cancer. There's just some types of prostate cancer that don't show well on prostate MRI. That's a fascinating topic, but we're not going to get into that today. The different issue is that the overall prostate MRI imaging quality and interpretation is, let's say, not uniformly super high in the community. There's lots of room for improvement. So it's one thing to miss prostate cancer MRI because it just doesn't show up. It's another thing to miss it because we haven't done a good job of imaging or we haven't interpreted it to the highest level. So that's, again, this recurring theme. Some of us are concerned about advocating for omitting GAD for general community practice. And when I talk about prostate MRI not being perfect, it reminds me of this ad for this LifeLock that they tell you how awesome it is, but then they tell you no one can prevent all identity theft or cybercrime. And it's just the point being, no test is perfect. And certainly MRI is not perfect, but it's better than the other options. So anyway, let's move on to looking at these troublesome cases. And here's a case where GAD probably does help us out. And this is an outside study that came to us. T2 images, not super compelling. Not really sure what's going on. You get to the diffusion images, and frankly, they're just really bad. Not really bad. The quality is just not anywhere near acceptable. ADC, bad, not acceptable, does not help. It really puts us in a bad position. Except we get saved here by the DCE. So here's an early phase of the dynamic contrast, and you can see that there's a brighter signal here representing the early enhancement. And that draws our attention now to the fact that there is this darker signal on the outer margin, left peripheral zone, that at first glance, you might have thought it was just part of the enlarged transitional zone, benign BPH, benign prostatic hypertrophy. But look here, this is what the peripheral's on the other side. So this, in fact, is tumor suspicious. It goes to biopsy, and it's an intermediate grade cancer. So in this case, if you had deleted the GAD, and you would have overlooked that, because again, the quality of the diffusion was just so problematic. So let's just look a few more of these type of cases. Another type of problematic case. This guy had already had his random biopsy, which turned up the lowest grade 3+3, just a small 10% in one core in the right apex. this PSA was continuing to go up and really wasn't explained by a little 3+3 cancer. Several MRs were interpreted as negative, but progressively increasing PSA. So here's an image that a couple things strike me right away. Number one is that this patient has not had a bowel prep. The diffusion images are gonna be horrible when you have bowel gas like this. And the second thing that strikes me is the transitional zone is not normal. Now, in the transitional zone, the dominant sequence you make your decision on is T2. So this should be recognized as abnormal. And there it is there. Now the diffusion, here's this black hole produced by the bowel gas, just really bad diffusion images. So bad quality, on one hand, and also overlooking the obvious abnormality if you've got experience reading prostate MRI. This has all the features on T2. It's homogeneous, low signal. There are no margins around it. There's no encapsulation. It's got lenticular shape. It's got all the features for a high-grade cancer. The report calls it negative. The patient comes for another scan for us on a higher quality study. You can start to see that's just diffusely abnormal. That's clearly a PIRADS 5 based on the T2, which is again the dominant sequence. When you give a bowel prep, even though it's not perfect, there's a little bit of gas. You clearly see the markedly bright signal restricted diffusion. And then when you add the RSI sequence, which is our advanced level diffusion, it's a light bulb there. So this patient then goes to in-bore targeted biopsy, and we get 3+4 and 5 of 5 cores. Note that we did not talk about DCE, gadolinium, in this case. So this is a group that's more of an advocate of less is better, shortening the scan, eliminating GAD. But the question then becomes, if you eliminate GAD, is there something that we might utilize to fill this gap? You know, we've talked about this rescue sequence issue. Is there something that when conventional diffusion fails that we can add in that will help less experienced readers and improve our identification of significant cancers? And they talk about these reproducible MRI related biomarkers, and they list a host of them here, different centers doing different work, but I want to draw your attention to restricted spectrum imaging that some of you may have heard of because it's developed here at UCSD, and we've adopted it for the last year and a half, and it is just a profoundly robust technique. And again, not going to get into the physics and math, but essentially it's looking at diffusion and going from diffusion, trying to separate restricted diffusion within the cell and within the compartments in the cell from restricted diffusion extracellular. It has lots of advantages in regards to geometric distortion. Specifically, it deals with bowel gas and bowel motion much better. And bottom line, clinically, we found it to be extraordinarily powerful in helping us to find aggressive cancers. So let me just show you a couple examples of this. So this is a patient that had a trust biopsy 3+3, 1 core. Question is there something more sinister going on? Can he stay in active surveillance? This is what prostate MRI should look like. I can't say that we always get this most gorgeous type of exam, but this is what we strive for. Just beautiful peripheral zones, extraordinarily well-defined margins, homogeneous bright signal, normal secretions within the glandular tissue. This is what BPH looks like. These are benign stromal nodules. Coronal imaging is ejaculatory ducts, just really beautiful anatomy, functional images, high B-value diffusion, absolutely pristine and normal. ADC, absolutely nothing worrisome. And of course, our RSI sequence will show some restricted signal in the benign stromal nodules, but there's absolutely nothing tumor suspicious here. So this is a PI-RADS1 high quality negative with a super low PSA density. This guy can with confidence stay on active surveillance. And again, contrast does not help us in this situation. Now this is a biopsy naive guy, a medical doctor. If you ever wondered what bladder stones look like, BPH, normal peripheral zone, beautiful transitional zone in the coronal plane and the sagittal plane, normal peripheral zone. Our physiologic parameters, normal ADC, beautiful T2. So ADC is a component of the diffusion sequence. And our RSI color restricted spectrum imaging color fusion overlay, totally normal. His PSA density is 0.06. So we can tell with a high degree of confidence, you can safely avoid a biopsy. The negative predictive value in a case like this is really in the 95% range. Doesn't mean he needs to be completely discharged. You can follow the PSA. If it becomes a problem, you can reevaluate. But at this point, there's really no need to go to biopsy, and he avoids biopsy safely. Now, here's a couple examples of where things are a little more difficult to figure out what's going on. The guy's had a benign trust biopsy. PSA keeps going up. Confounding, where this is going to cause us some problems. The bright T1 signal here is hemorrhage from the biopsy. So now when you go to the T2 image, it's uniformly dark signal, an example of how not everything that's dark is cancer. That's because of the hemorrhage, or at least partly because of the hemorrhage. Now our diffusions are not going to look extraordinarily gorgeous. Nothing pops out. Perhaps some bright signal here, diffuse dark signal in the T2. Maybe some low signal in the ADC. But when you get to your advanced level RSI sequence, this restricted spectrum imaging, clearly something's different from everything else. For me, that's extraordinarily helpful, looking at literally just under 5,000 exams. This gives me a lot of confidence that this is in fact the abnormality. Certainly for a less experienced reader, that's going to be profoundly helpful. RSI map, bright light bulb, color fusion, pops, beautiful fuchsia, whatever. So he goes to targeted biopsy. We do an in-bore biopsy and get 3+4 and 5-7 cores. So restricted diffusion, sequence and advanced level diffusion, super helpful in these complex cases. I think that this might be the last one. This patient has not had a biopsy, comes to us, and here's another example of just homogeneous background, low T2 signal. How was going to pick out a cancer in there? Hard to say. Notice the black signal here in the central part of the gland, the transitional zone. That's produced by this calcifications in the transitional zone. Those are benign calcifications, but they produce marked artifact on the diffusion sequence, kind of a black hole here. However, when we go to our RSI, extremely obvious. It sucks out all the background signal and draws our attention to the markedly restricted signal in the gland, really the right peripheral zone from the base through the midgland to the apex, some extraprostatic extension. So this is the PI-RADS5 lesion. Comparing the high B value diffusion versus RSI, this is slam dunk. ADC versus RSI light bulb. Now he goes to a fusion biopsy. The target's 4+4. Not a surprise that the adjacent cores that were taken as part of the systematic biopsy, in addition to the random biopsy, on the right side all came back positive. Note, however, benign, everything's benign on the left. So the MR nailed it, restricted spectrum imaging nailed it. I did not show you any contrast images. Last one, just very briefly. T2, hard to tell. Diffusion, maybe some bright signal on both sides, maybe some low signal here. I'm not confident. However, when I do my RSI map, this becomes very apparent. I can go back and see, yes, this is homogeneous, poorly circumscribed, no definite capsule, markedly restricts water, goes to a fusion biopsy. The target is 3+4 and everything else is negative. So super helpful parameter. Again, contrast does not come into the question here. So kind of summing up, if you omit GAD, it's called biparametric, and simply that is a anatomic T2 weighted with the DWI. In our practice, that's DWI conventional as well as the restricted spectrum imaging. In the community or in general, if the GAD is omitted, you can call the patient back if the study is non-diagnostic because of degraded diffusion images, and that's a reasonable protocol. I just want to point out down here, GAD biparametric protocol is not in play when you're just talking about tumor recurrence. It's really helpful for us, patients who had radiation therapy or focal therapy or radical prostatectomy. So we would not talk about biparametric protocol in patients who have had treatment. So how should we think about scan? Do you like your scan with GAD? I think there's a couple things we can say definitively. Gadolinium is not necessary for follow-up for active surveillance after the initial baseline MRI, and that is exactly the Sloan-Kettering protocol. Another thing we can definitively say is that patients should be accommodated if they prefer biparametric. If they don't want contrast, that's fine. That happens very frequently, and we always accommodate the patient. If you're utilizing restricted spectrum imaging or some other advanced diffusion, artificial intelligent type of biomarker employed in expert centers allows the option to eliminate GAD without compromising sensitivity and specificity. And finally, and this is, maybe I'm waffling a little bit, but I think you really need to have caution and circumspection regarding non-expert centers adopting a biparametric protocol because of the issues we talked about with overall quality and expertise of interpretation. So that's really what I wanted to talk about. And again, I hope it was of some interest to you and happy to take any questions.
Well, thank you very much, Doctor. A lot of information there, a few new terms that I'm not familiar with, but it definitely, it's not like that was a discussion that went on with any doctor of mine before I had an MRI or CT scan in terms of like, what are they going to be injecting into my body? So it's nice to know that there's a lot more consideration of the effect of these contrast agents. Yeah, I myself, I did have the Mpmri at UCSD without an injection. So I guess actually in that case, it was discussed ahead of time.
So you did or did not have the contrast?
I did not have any contrast at that time. It was only when I had just a CT scan prior to my radical prostatectomy that they used the radioactive contrast agent, to my recollection.
Okay.
But that was not at UCSD. That was over at Sharp Memorial.
Okay, got it.
Yeah. So we have a couple of questions coming in. If you could take a look at that first one, there's a rather long description of what Lance is going through.
Hang on a second. Let me just find.
Oh, yeah. Can you find the Q&A?
Let's see. I got to figure out how to. I know what I'm going to stop sharing, and then I'll be come up. Okay, good. Participants, more raise hand. Q&A. Okay. I had a 3 poke and hope prostate with a result of Gleason 3+3, where the cores were 4, then 10, then 7, ranging 2 to 40%. I've had 4 prostate MRIs, each about 6 months apart. The first 3 were grade 2, 5, nothing notable. My PSA was. Okay, so the question is, how common or uncommon is it for an MRI to change from pyrites 2 to pyrites 5 with a 15-month period? That's a good question. So, and the answer I think in general would be not common. And I think some of you may know that even prostate, if you look at prostate pathology, if you look at biopsies, many of you probably know that there's a lot of inter-observer disagreement, meaning you get the tissue read by one pathologist and he says it's 3+3. Then you take it to somebody else, he says it's 3+4. I think a lot of you heard the name Jonathan Epstein, who's an expert who gets sent tons of pathology. And so the point is that these prostate MRI is not a black box where the answer spits out, as I've tried to note in my discussion. So that my first thought would be that, you know, somebody perhaps didn't read the exams exactly correctly, frankly speaking. So it's to answer the question, I'd have to see the images, but it sounds like with the persistently elevated PSA, with the fact that under pathology they did find some cancer, and that now in MRI somebody's saying there is a significant lesion. Yeah, a targeted biopsy is absolutely the way to go. If you'd like, I'd be happy to look at your images. You know, I offer that to patients, but that's the general answer to your question. But something might have been there that was overlooked on the earlier studies. I think that's more likely than something developing in a 15-month period. So can you please define expert versus non-expert centers? So good question. Basically, it's like anything else, whether you're a radiologist, a carpenter, you know, a painter, how many have you done? How dedicated are you to whatever you're doing? In the literature, they define expert as 300 cases per year. In other words, somebody's reading 300 prostate MRIs per year. This year, last year we did 1,500, and this year we'll probably do about 1,800. I'm not a genius. I'm not smarter than the next guy, but I have dedicated myself to becoming as good as I can be at interpreting these studies, and as good as I can be at getting the highest quality imaging. That's what I would say. An expert center is a place where people have decided they're going to strive to do the best they can do. When I first started, and I was starting at 0, I had my cases overread by an expert. So Bernadette, I mentioned, I'm very acquainted with. She's with John Feller down in Palm Springs, who now is the medical director of Halo DX. I trained with him. He was, I knew him for years since we trained together at Stanford. But when I started prostate MRI, I went to his center, spent hours and hours and weeks with him, and then had him overread my studies. So to me, an expert is somebody who's dedicated to putting in the work to get the best exams and to figure out how to read the exams at the highest level. Next.
One thing I'd like to, I guess, add into that question is, with all the use of artificial intelligence these days, do non-experts have, I guess, access to any kind of expert type of centers using AI, such that it's more of just like, hey, I'm just getting a computer to check that report, as opposed to, you know, taking time of another doctor?
That's a great question. Not as of yet. No, not really. That's certainly being looked at, and tons of money and interest in that across the board for all sorts of things, but certainly in imaging. It doesn't exist as of yet. What does exist is plenty of opportunities for people who don't have much experience to go to conferences, go to dedicated training sessions, come to guys like me that have thousands of cases with rad-path correlation to sit down, you know, and review this stuff. But it's effort-based, frankly. And, you know, and at some level, you just need to be willing to do that. And on AS, how often should I have follow-up Mpmri, and should it be driven by PSA numbers? Another great question, and that's evolving. If you think about initially with AS, there was really intensive follow-up, including biopsies, sometimes every 6 months, because there was really the natural history of guys that were not going to get treated with this low-grade cancer that wasn't clear what the natural history was going to be. But now, as things have gone on and people are much more comfortable with active surveillance, those protocols requiring biopsies, they're not uniformly adopted. And similarly with MR, if you have a high-quality negative MR in a setting of active surveillance and your PSA density is low, so as some of you probably know that PSA density is simply taking your PSA value and dividing it by the size of your gland. So you get a prostates vary in size. One guy might have a 30 cc gland, and one guy might have a 100 cc gland. So 0.15 and below is considered a good prognostic indicator that you don't have a high-grade cancer. So if you have a negative prostate MRI and a low PSA density, probably you could talk about every 18 months unless your PSA started going back up. I don't know if the literature is specifically given you know, it has to be done this often or that often, but if I was to see in an individual patient a very high quality negative prostate MRI with low PSA density, I would feel very comfortable in not having them come back for an MRI unless something drastically different happened with the PSA. Lance Clifter says there was a second opinion in my biopsies that matched the initial reads. That's great. You know, how many MRIs would it take to consider a considerable amount, and over what time period? Would you? So I would say, frankly speaking, for me, it took hundreds. I mean, so like I said, in the literature, the kind of the general consensus is you should be reading 300, you know, a year to kind of stay up to to par. And if you look at breast imaging kind of as an example, if you're doing breast imaging, reading breast mammography and breast MRI, you have to keep up your number. So every year you have to read a certain number to be so-called, get what they call MQMSA, which is a law to demonstrate that you're staying up to date. That hasn't happened yet with MRI, but I would say you need to be consistently reading a certain number, and I would say 300 is probably the minimum per year to have a good feel and be comfortable to do a solid job.
What maybe Rich can elaborate a little bit more. When I first read that question, I wondered if he meant how many MRIs with GAD, if he were to have GAD and MRIs, a number of times, how many times is it considered considerable?
Well, I think that's I got it. I got you. Sorry about that. That just shows that I missed the lecture on read the whole question before you start to answer it. I remember, just I think the more important question is risk benefit. In other words, if you're having these multiple exams with GAD, is the GAD adding value in each of these exams? So, for instance, if you've got a brain tumor and every time you're getting a brain MRI, and again, I'm a neuroradiologist, I see this every day, the results of that exam are going to drive treatment decisions. I don't think you need to get the gadolinium because it's profoundly important. If, on the other hand, you're getting a prostate MRI for the fifth time to file on active surveillance, and you're getting GAD administered each time, I'd say that's a considerable amount of gadolinium administration, particularly given, in my opinion, it's adding little to no extra value. That's how I'd answer that question.
Gotcha. I think I saw on one of your slides, you said like 30 to 40% of MRIs, I think if I recall right, came back as negative and therefore would not have been useful to have GAD. Sorry, a whole bunch of noise outside suddenly, but so like bottom line, the number of patients that came in, if you had 100 patients came in, what percentage of those patients would you likely administer GAD to?
Well, I think the default has been, and this is kind of a more, the default has been to offer the Mpmri as our standard test. Mm-hmm. However, as things have evolved and we've started to realize, particularly with this next level diffusion, for instance, that it's a negligible number of cases in which GAD adds significant value. Margolis talked about how it's really crucial deciding the size of the gland of the tumor. I don't know if you remember that, which in general, we have to remember the prostate underestimates the size of tumor. We know that. If you look at MRI, whether it's with GAD, without GAD, however you're measuring the size of the tumor on MRI, if you then look at the specimen under the microscope after they take the gland out, it's going to be bigger. And I like to use the example or the image of, we can see the body of the spider, if you will, but we don't see those little spindly little legs that are extending off around it that they see on pathology. So it's true that, maybe contrast will show a little bit, a slightly better estimate of the size than the other sequences. But for the most part, after you looked at thousands of MRIs, it's a very small percentage that contrast is going to change my overall assessment. In other words, if it's going to be a negative study, the contrast doesn't help me. If it's a clearly positive study, the contrast doesn't necessarily help me. If it's a borderline study and I might have overlooked something, the contrast does help me, but that's a very small percentage of the time. So really the question gets to be, are we ready to adopt across the board non-contrast imaging? And we're having those discussions, and part of the issue is it becomes complex for the ordering physicians. You know, they don't want to have too many boxes to check about what type of prostate MRI they're going to get. It becomes problematic for our schedulers and such. So we're kind of in the middle of trying to navigate those kind of complexities. Does that make sense?
Yeah, it does. Does getting an MRI itself, I mean, my impression is that getting an MRI doesn't, as long as there's no contrast agent, doesn't really affect your body. You know, like you're not having like radiation in the way of x-rays and so forth. I mean, so if a patient just, you know, nobody gets the GAD coming in and you just decide, all right, we're just going to have to subject this person to a second MRI, there's not really any degradation of the body on getting multiple MRIs themselves, is there?
No, absolutely. You're absolutely correct. And the only downside, there's two downsides I can see if you completely omitted gap contrast cost of three downsides. Let's go start with the first two. The one is you could say delayed diagnosis. So let's say, you know, maybe it takes X amount of time for the patient to come back to get that study, and you go, oh, you know, we could have made it 2 weeks earlier if we would have done the GAD at the time that the scan. So that's, you see what I mean? But that would be the one negative against excluding the GAD initially. The other would be, are there cases that, what percentage of cases would GAD help me that I don't recognize without GAD? Does that make sense? You know what I mean? That something that perhaps the gadolinium would have alerted my attention to, even with all my experience and with this next level diffusion I'm using. Is there other cases where the GAD would really save the day? That's a reasonable question. And then the bigger question, though, I think, is if there's a trend to move away from GAD, again, what about the places that are not getting the good quality imaging and they don't have the expert or experienced readers, and then they're discarding a sequence that is actually probably the easiest and the most likely to be high quality for whatever reason. I'm not going to get into why the gadolinium is kind of a more bulletproof, technically easy sequence. If you get rid of that, are you going to introduce more errors into the whole imaging pathway? So those are kind of the three things in the back of my head about if you adopted a uniform omission of gadolinium. Larry Weaver, I think I know Larry Weaver. What indications would indicate? So what indications would indicate that gallium-68 PSMA PET CT should be done next? Two ways to answer that. One is PSMA PET is the gold standard for what's called whole body staging. So MRI has been considered the gold standard for local staging. Is there a tumor in the prostate? Where is it? How big is it? Can I target it? Can I biopsy it? If there is a cancer, is it extending outside the capsule? We've got high spatial resolution. We can see the margins of the gland. We can see if there is extension beyond the capsule. So the MR is considered the gold standard for the local staging. PSMA PET is considered, is the gold standard for whole body, meaning is there spread beyond into lymph nodes that are too small for me to pick up an MRI or outside my field of view? Because the MRI is only looking at the pelvis, particularly the prostate area, and I'm not going to see lymph nodes beyond the aortic bifurcation. So the answer is, if you have a high grade, highly suspicious cancer, and your PSA level is very high, and the nomograms suggest that you have a significant risk of having metastatic disease, then you probably need a whole body staging. And PSMA would be the best way to do that. It's much better than CT. So that's the answer. The next question is PSMA PET becoming so good that it can replace MRI for local staging? And the answer is not yet, but what is fascinating is PSMA is PET MRI. Now, there are some places where you can administer the PET agent and then scan with MRI. So now you have the advantage of the physiologic, the PSMA antigen ligand, and the high resolution, spatial resolution of MRI. And that would be, if I had $100 million and I could buy a toy, that would be one of the toys I'd buy. But the general answer is, for PSMA PET, it would be in a patient that has a high-grade tumor that we haven't seen spread outside the capsule on MR, but perhaps there could be some lymph nodes somewhere else that would change the treatment.
All right, excellent. Anyone else out there have any more questions they'd like to ask Dr. Schwartzberg? Yeah, we did have about 25 people attend today, and we'll get a lot more in the next few weeks once it's posted to YouTube. But Doctor, great presentation today. Certainly one that I will be actually reviewing to make sure I picked up all the terms and subtleties and so forth. Thanks so much for your time. We do appreciate it. Certainly on behalf of Gene and Lyle and everybody else, we thank you very much for your time.
Sure. I just have to say one thing, which is appreciate it. It's a pleasure to come before you guys, and I'm a huge fan of your group and what you do. And I know Bill Lewis, and I'm telling you, I'm looking forward to reading Bill Lewis's notes, because he'll teach me things that I didn't know, because he's so thorough and so great. So again, thanks for having me.
All right. Thanks a lot. See you all next month, everybody.